welcome to another session of EMI Live. This is an initiative from the Clinic Endocrinology and Metabolism Institute for educational sessions that are available to community endocrinologists, and the recordings are put up on YouTube as well. As usual, we start with a case. Today's case is being presented by a first-year clinical fellow, Dr. Khaled Alsibai. And on the panel, we have Dr. Marwan Hamaty, who is the staff on the case, Dr. Nasr, who is the medical director of the Thyroid Center of Excellence for the clinic, and Dr. Pratibha, who is the medical director of the Adrenal Center of Excellence for the clinic. Dr. Alsibai.
Good morning, everyone. Thank you for joining in. It's my pleasure to present today's case presentation. Special thanks to Dr. Hamaty for sharing the case. Special thanks to Dr. Nasr and Dr. Rao, Dr. Makin for their help and valuable feedback. Our case for today is a 46-year-old gentleman who's presented to the endocrinology clinic for establishing care. He has established hypothyroidism and questionable or possible adrenal insufficiency prior to presentation to the clinic. The history started about 9 months prior to the appointment when patient was admitted as inpatient after a pre-syncopal episode that led to a motor vehicle accident. He had some symptoms for a few months of fatigue, excessive sleepiness, dry skin, blurring of vision, weight gain, numbness, tingling, and imbalance. Okay, can you hear me now? So, past medical history of Crohn's disease and active tobacco smoker, no prior surgeries. Mom has a history of thyroid disease with no other details available. A maternal grandmother with history of type 2 diabetes. He's an active smoker, has a 20-pack year smoking history. Social drinking with no reported excessive alcohol use. He's sexually oriented to male and denies any recent sexual contact. He works as a general manager at a restaurant. Not actively on any prescribed medications. And review of systems, it's pertinent for dry skin, blurring of vision or double vision, numbness and tingling in hands, fatigue. However, other review of system is unremarkable. On physical examination, his vital signs were stable. We can say soft blood pressure, but otherwise vital signs are normal. Physical exam by documentation was unremarkable. Like thyroid exam did not show any enlargement or discrete nodules. No symptoms of like no cushingoid features observed in exam. In workup, he had a new onset bicytopenia that was not detected in prior CBCs. His chemistry showed low calcium, but after correction to albumin, it's 8.7, so within the range. And there's also new finding of low albumin that was not present in prior lab testing. But otherwise, liver function, liver enzymes, and liver function test is normal. Potassium, sodium, glucose, and kidney function are also normal. There was also reported subjective fever, so inflammatory markers were checked, and he had elevated citrate and C-reactive protein. And I guess given the acute bicytopenia, HIV testing was done, and he had high viral load in the PCR. Given the fatigue and the soft blood pressure, thyroid function panel was done, which showed markedly elevated TSH of 106, low free T4 and free T3. ACTH stimulation test was done, and that was around noontime. He had a basal cortisol of 6.2, and then he stemmed to 16.2 at 1 hour after the cosintropin. That was at the time of the prior assay where the cutoff was 18. So that was labeled as inadequate response to the cosentropin, and patient was labeled with adrenal insufficiency. Other workup included TPO antibodies that were negative. Adrenal antibodies were borderline elevated, and ACTH was less than 5, which you can argue is inadequately elevated.
I'm going to stop you there. Khaled, we are going to start with Dr. Hamaty. Dr. Hamaty, what prompted the HIV diagnostic workup for this patient?
Good morning. The patient had several unexplained symptoms and fever, and especially the abnormal blood count that was main key in bringing the attention to the HIV. Later on, the ultrasound of the thyroid, which, the thyroid abnormalities were kind of another hint that brought the attention to HIV. But he was pretty sick during his admission. I didn't see him. It was one of our colleagues who saw him during his hospital stay. But from the chart review, it seems that he was pretty sick. And the fevers were not well explained. So it was within the fever workup and blood count abnormalities.
Okay, thank you. We are going to go to Dr. Rao. And Dr. Rao, what do you think of this ACTH stem test?
Thank you, Dr. Makin, for that question. See, because he was acutely sick, as Dr. Hamaty mentioned, I'm not sure how much weightage to give to this ACTH stem test, because literature has shown that up to 40% of adrenal insufficiency is falsely diagnosed when there is hypoproteinemia and there is an intact HPA axis. And as we all know, albumin is the most abundant protein that's available, and it's the biggest buffer to keep maintain the steroid hormone levels. And 10 to 20% of the cortisol is bound to albumin, and 70 to 80% is bound to CBG. And we can assume by extension that if albumin is low, even the CBG may be low. So he is almost there to the 18. So it may not be true adrenal insufficiency.
So that kind of, now we have somebody who has clear hypothyroidism and questionable adrenal insufficiency. So then the question becomes, do we treat this gentleman with steroids presumptively before we give thyroid? I know we have Dr. Rao here, we also have Dr. Nasr here. What do you both of you think? Pratibha, you want to go first?
Oh, yes, so thank you, Vinni. And I was actually going to ask Khaled, was this patient treated with hydrocortisone before he was started with levothyroxine, given that presumptive diagnosis of adrenal insufficiency, or not?
Yes, that was the case. He was started on stress doses of steroids prior to initiation of levothyroxine therapy, and yes, they were cognizant of possible precipitation of adrenal crisis if levothyroxine was pursued before the hydrocortisone. Yeah.
And this ACTH of less than 5, was it tested after the patient was already started on steroids?
Prior.
It was prior. I'm not sure we have a clear explanation for this.
For the loss.
All right, we have a raised hand. Let's see. Dr. Feynman.
Sorry, I was muted there. I'd like the panel to discuss what pituitary function is like in somebody who has severe quote unquote primary hypothyroidism. Long time ago, it was clear that anterior pituitary insufficiency could be corrected simply in these cases with treating with thyroid hormone. I do agree that with caution in the wind, covering short-term steroids, but don't complicate the issue with long-term therapy.
Dr. Nasr, can you comment on this?
Well, so far from the information that you're sharing with us, it looks like primary hypothyroidism. I can't make any speculation about the etiology of this. So it could be after a course of thyroiditis, or it could be a chronic lymphocytic thyroiditis. The physical exam from what Dr. Alsibai is describing, he didn't feel, or whoever examined him at that time didn't feel a goiter. There was no mention of any pain to suggest subacute thyroiditis, unless I missed something. So right now we have a case of primary hypothyroidism.
Okay. All right, Dr. Alsibai, do you want to?
So moving forward, other workup included imaging. So the CD adrenals were imaged and no adrenal lesions were identified. CD of the neck was obtained, which showed erogenous attenuation of the thyroid gland with diffuse enlargement. MRI of the brain, which was done, which didn't show any pathological abnormalities in the pituitary region, and no other acute intracranial findings. These are some images of the thyroid ultrasound. As you can see, the diffuse enlargement, the echogenic foci that are more prominent.
I am going to stop here and ask Dr. Nasr about his opinion of this ultrasound.
So by the shown measurements, it looks like this thyroid is, these lobes are larger than a normal thyroid. The echogenicity of the parenchyma is heterogeneous, a little hypoechoic. Plus, we see in this what we call a starry night with a multitude of punctate echogenic foci that are present in both lobes from what Dr. Alsibai is showing. So we see this sometimes with diffuse lymphatic involvement by papillary cancer, or given the setting of immunocompromised person, we should consider the possibility of a fungal infection of the thyroid.
Okay. Thank you, Dr. Nasr.
Thank you. So as Dr. Nasr explained, he had the diffuse thyroid enlargement, the echogenic foci, differentials given that it could be infectious etiology, like opportunistic infection, like fungal infection, or neoplastic or inflammatory cause. FNA was recommended. The impression by the consulting endocrinology team during that admission is that patient has an unusual case of thyroiditis, which could be an opportunistic infection given the immunocompromised state and the new diagnosis of HIV. Patient was recommended to follow up as outpatient for FNA. That would be sent for fungal staining. He was discharged on levothyroxine, 137 microgram daily. The ACTH stimulation test, it was labeled as inadequate, and he was started on hydrocortisone and discharged on 15 and 10 milligram. He was also started in Bactrim and Zithromax for PCP and MAC prophylaxis. He did not follow up due to insurance issues, and the next slide I'll show you the next event that happened. But yeah.
So here we are very fortunate to have Dr. Grinspoon with us. Dr. Grinspoon is an expert on HIV-related endocrinopathies and as our speaker for 7:30. Dr. Grinspoon, welcome. And what do you think of the case so far? You're muted.
Can you hear me? Can you hear me now?
Yes.
Yeah, sorry. Yeah. I think it's an interesting case. I think I agree with what's been said. I think it's kind of potentially a borderline adrenal insufficiency case, but I would also have covered with steroids. There's no question about it. I think a biopsy would be necessary. You can see, acute infectious causes of thyroiditis in patients like this or malignant. So I think you have to rule out between those two. The other thing is, was he or will he be shortly started at that time on HIV therapy for his acute HIV?
It was planned to be done in outpatient with infectious disease.
Yeah, because the other thing is that they can have an immune reconstitution syndrome. So you sort of have to watch that moving forward in this patient to make sure that he doesn't have any of those. So yeah, I would be very curious what the biopsy show. It's a great case. Thank you.
Dr. Grinspoon, can you talk a little bit about the immune reconstitution syndrome and what would be the things to watch out for in this case?
Well, people can have autoimmune thyroid, adrenal disease. This person presumably has some infiltrative disease of his thyroid, but people can have Graves or other types of situations. So I don't think that's going to be, I think this person is distinct in this regard because he has an infiltrative disease. But I'm just bringing up the point because if you have any kind of autoimmunopathy going in and you treat acute HIV, you can get an immune reconstitution syndrome, and not just endocrine, but in many organs. And it can be severe. It's not very common, but it's seen in enough people that you want to make sure, particularly if someone has, a borderline autoimmune adrenalitis or something that could get worse, or pituitary, et cetera. In this case, I'm not exactly sure what his adrenal, if he even has it, and what's causing it.
Okay. Usually when somebody has immune reconstitution syndrome, so this person, let's presume this is true adrenal insufficiency. Would the patient need stress dose steroids at the time?
No, not necessarily, because I think, if they're not sick, you're at least covering, well, I should say this person is sick, but I don't think they need 100, of hydrocortisone Q8, that kind of dose. But I think, titrated to the illness of the person. I mean, it's not automatic, but I think it really depends on how sick the person is,
Okay. All right. Thank you. Dr. Alsibai.
Interval events before establishing care with endocrinology and ID, the patient had to be readmitted for acute presentation of abdominal pain, diarrhea, and blurring of vision. EGD was done, which showed erythema and linear ulcers in the esophagus, and biopsy confirmed CMV esophagitis in the mid-esophagus. Also, eye exam revealed intraretinal necrosis of the left eye, suggestive of CMV chorioretinitis. He had high titers of CMV DNA, suggesting CMV viremia. He was started on IV ganciclovir, and during that admission, antiretroviral therapy was initiated. And follow-up with endocrinology, that was 9 months after the first presentation. His TSH and free T4 normalized with the use of levothyroxine. A random cortisol and ACTH were checked in the afternoon while patient without holding hydrocortisone, and cortisol was 5.2, ACTH was 11. A repeat ultrasound was done, which showed interval decrease of size in the thyroid gland and less prominent echogenic foci. A brain MRI was repeated, which showed no pituitary abnormalities. Hydrocortisone dose was tapered to 10 and 5 from 15 and 5. And here you can see the repeat ultrasound images, so decreased dimensions and less prominent foci as well.
Dr. Nasr, would you like to comment on this repeat ultrasound, please? Okay, I think we have lost Dr. Nasr. He was great enough to join us from his vacation virtually. All right, let's move on to the next slide.
So the current working plan and impression by endocrinology, so the appearance of the new ultrasound is similar. The appearance of the initial ultrasound was similar to reported cases of pneumocystic thyroiditis. Given the interval improvement in the size of the goiter and the resolution of the echogenic foci, it was deemed that FNA is not indicated, that it's not going to change management, essentially.
Oh, wait.
Yeah.
Dr. Nasr, I think we lost you for a second on the ultrasound images. Can we go back one? Yeah, any comments on this? Next.
Right. So, yeah, sorry, I was disconnected for a few minutes. Given that he doesn't have any discrete nodule and that we're not seeing this same enlargement, the diagnosis of malignancy was less likely. And since the possibility of opportunistic infection of the thyroid was more likely, I didn't want to subject him to a fine needle aspiration. I'm not sure if we were going to obtain a meaningful sample now that the echogenic foci were fewer, but it could have supported the diagnosis, but I didn't think it was needed at that point.
Is there any, so if let's go back to the previous ultrasound, would there be any benefit of doing a biopsy at that point to look at the organism and possible sensitivity to antibiotics? Is it usually done? I have no experience with HIV positive patients with these kind of thyroid presentations.
I think Dr. Grinspoon will tell us more about this, but I don't think seeing the fungi or I don't think it's considered a parasite anymore. But I don't think seeing the organisms will or testing sensitivity is needed because the sensitivity of this pathogen is known, and it's seen in a setting of diffuse or multi-organ infection. So I think the patient, if you decide that you're going to treat them, it would be something systemic. But again, I'd like to listen to Dr. Grinspoon on this.
Well, I think pneumocystis was part of the differential. I mean, I guess I might have been tempted to do it just. I mean, pneumocystis, the treatment for that is treat the HIV. CMV, he was already being treated. He's going to get treatment for. Fungal, that may have required additional unique therapy that he wasn't offered. I mean, I think that as, time, tincture of time always, in this case, you were absolutely proven right. I mean, he did fine. I think if his thyroid was getting larger, more painful, so you would have biopsied that. There's no question about it, But I guess out of curiosity, I might have, but I get malignancy too, but that's less likely than an acute infectious process. I agree. I mean, I'm not a thyroid expert, but given the acute setting, I might have maybe ruled out fungal infection is the one thing perhaps I might have ruled out. I don't think he was treated for that. But anyway, in any event, you were correct. He did fine.
Okay, thank you. We have Dr. Adi Mehta with a comment or a question.
Yeah, hello. I'd like to play a bit of a devil's advocate here, because this is really doesn't fit any sort of physiology. You have a patient who has a low albumin. By rights, that low albumin will translate into low cortisol levels. So therefore, in this case, the better test would have been to look at free cortisol in the serum and during the ACTH. Furthermore, he's got a suppressed TSH, which may be due to the severe hypothyroidism, which certainly does not indicate adrenal insufficiency. Unless someone's telling me that there's a total disconnect, we have a problem. Thirdly, we use the dose of steroid. There was clearly just to cover our rear ends, because this dose of steroid in someone who's stressed is going to do nothing. And we're just trying to say to someone, well, we thought about it and we treated it. So from an educational point of view, we were just not looking at this very physiologically. We were just doing this to cover our rear ends, because none of this makes any sense. This gentleman had a normal adrenal response in the face of severe hypoalbuminuria, severe malnutrition. So let's be clear. This was not done scientifically. It was done for purely medical legal purposes. I'm maybe coming out a bit strong, but I think it's very true that this does not fit physiology.
Thank you, Dr. Mehta. We actually have a slide right now on that. I know Dr. Rao has a comment on the free cortisol part.
Yes, thank you, Dr. Mehta, for bringing that up. And while it's great to do the free cortisol, it takes forever to come back, and it's not really clinically helpful at the time when we actually need it. And, the function of free cortisol, how it behaves in health and disease is not yet completely known. And I'm not sure by sending it out and getting it later, how it would have helped us in the management at that time.
I agree with that. It's a send out in our lab. It takes 2 weeks to come back. So it's not practically useful at the time of the hospitalization. I can understand some of the issues around this, that with that high a TSH, the primary team was very leery of treating the hypothyroidism with that borderline cortisol.
The other thing is, just to add a point, if you had your MRI, which cleared any kind of mass, but before you did, you could have acute secondary adrenal insufficiency, and there could be a very adequate response to ACTH, but you could be burned and fooled. So in the beginning, it is I think it's more than covering your butt. I think it's the safe thing to do. I mean, I agree that you need to watch the person over time, but in the absolute acute setting, I mean, I think giving some steroids in the context of giving thyroid hormone is the appropriate thing to do.
Thank you, Dr. I agree with you, Dr.
One thing about the history, the patient has history of Crohn's disease and prior steroid treatment. The ACTH system test ruled out primary adrenal insufficiency, the issue of exogenous suppression by steroids. That's would be another possibility in the evaluation. So if I were to be in the hospital at the time of the patient presented, probably I would have given a steroid as well.
Thank you. Dr. Hasni, you have a comment or a question? Please unmute yourself.
Yeah, thank you. So I just wanted to comment on the adrenal insufficiency part. So, I agree with the cortisol, the free cortisol level is helpful in such cases. We used that also when I was at Hopkins. So, I think it helps in retrospect, and it wouldn't hurt to treat the patient temporarily with adrenal insufficiency, because, we don't want to miss that diagnosis until, we get the more information from the free cortisol. The other thing that I wanted to comment is, as far as I remember from the result, I think his peak cortisol was 16. And yes, and when someone is critically ill, we know the adrenals, they lose the normal peak response. ACTH stimulation test is what it was really meant for the outpatient, not the, inpatient evaluation. And we have to be careful also with the literature that propose using lower cortisol levels, because most of the studies actually they have limitations. We did, I looked at them with Dr. Marwan, and we have actually we are looking at a retrospective study. We are at the final stages. Most of the literature, actually, the studies that proposed lower cortisol cutoff, they had a lot of limitations. For example, inadequate cortisol washout, patients were taking steroids and they were checked, they were involved in the study a week later and things like that. Opioid dose, they did not exclude patients on high opioids. So we have to be careful with, with the lower cortisol cutoffs. When we looked at, our cohort, we found out, yes, at the 60-minute, we should use lower cutoff, 18, but the 30-minute should, 15, I'm sorry, but the 60-minute should still be, more than 18, but we can't use 15 for 60 minutes. We felt that it was inadequate. So I just wanted to comment on that.
Thank you so much, Dr. Hasni. It's interesting you named Dr. Hamrayan. He's coming back for our EMI live rounds in January. So we will have a chance to see him virtually and talk to him about his wonderful research. I think we need to wrap up the case a little bit.
Sure. So as you can see, the cortisol response is now improving with elevated ACTH. That could be a recovering pituitary acute dysfunction with acute HIV setting, or a recovering primary adrenal insufficiency with iatrogenic use of hydrocortisone that is being tapered now. The plan is to retest the hypothalamic pituitary adrenal axis by holding hydrocortisone night dose and repeating 8 AM cortisone ACTH.
I think we are going to finish here. We are at 7:30. Dr. Hamaty, since you're the staff on the case, any final words?
Well, I think still it is yet to be established the current steroid status, whether his cortisol is appropriate for him. And this, especially the ACTH response, is it recovering pituitary, the adrenal not fully recovered, or if it is a mild case of primary adrenal insufficiency that it might progress over time. One thing to mention, the adrenal antibodies were borderline. So they were not negative, not impressive in terms of positive. So it's difficult to ignore altogether. And as Dr. Greenspoon mentions about the risk of activation of disease as HIV is treated, that's a concern. And because of the lack of or concern about possibility of lack of follow-up, I favor to continue hydrocortisone at the time of those tests, awaiting repeat evaluation.
Thank you so much, Dr. Hamaty. Wonderful case. Thank you, our wonderful panel, for all your input. Dr. Alsibai.